Or Dr. Greenberg, do the welcoming sort of reception, but just want to introduce myself briefly. My name is Christian Morris. I currently work at Us Helping Us in the research department as a research coordinator. Basic information about me is I really believe in community research. I love asking questions that we don't know the answers to, and I love bringing that information back to the people who are centered in that research. That's my motivation in being a part of this call today, but also just doing the work that I do. So I'm happy to be amongst the like-minded people. Again, my name is Christian and I'm at Us Helping Us. And I'll introduce Dr. Greenberg, who is the director of the DC Center for AIDS Research, as well as a professor in the Department of Epidemiology within the School of GW. So Dr. Greenberg, if you want to join and open up the space.
Sure. Thank you, Christian. We're so absolutely delighted and excited to be here for the 11th anniversary of this event. Lorena has just put up the agenda. Christian, do you want to go through I guess that passed. So we'll.
I can go through the agenda real quick if you want me to, and then you can do welcome reports. Yeah, so we're getting started. Alan's gonna really ground us in the space and while we do this in the 11th edition. From there, we will have two scientific presentations, if you will. These are primary investigators whose work has been represented at the conference earlier this year, which is CROI, of course, that's why we're here. And we actually have some community responses who will respond to each of those scientific investigators, sort of help us start the conversation on the impact that the work has on community and people's real lives. So we'll go with Alan, then we'll have our first scientific presentation, our first community response, then we'll have Manya, our second community response, and then Melissa will wrap us up in the end. So that'll be the flow for today. I think with that, Alan, feel free. And this is the planning team real quick. Myself, George Kerr with the DC CFAR, Lorena, and Melissa. So go ahead.
Thank you. And it's just a joy and an honor that the community has invited us back year after year to meet with you and to share some of the information about CROI. And we're so delighted to be here once again. Next slide. So very, very briefly, CROI 2023 is it's the major annual HIV scientific conference in the United States. It was held in February of this year in Seattle, as it has been every year, but there were many more people in person. I was not able to attend in person, but I attended virtually, but many of our faculty did. And this year it also included many presentations on COVID and Mpox, which was important as well. We had a number of investigators who actually presented at the conference, Dr. Castell, Dr. Anderson, Dr. Scott, and Dr. Ward. And so we were very honored that our CFAR was represented at the conference, and our speakers today were in attendance as well. Next slide. And for today's annual update, we're just grateful to the CPC for continuing this rich tradition. It's a forum for direct interaction between DC HIV community members and DC CFAR investigators. We like to think that it brings up-to-date scientific research findings directly to the community, and it provides opportunities to discuss research findings, ask questions, to hear the community perspectives on so much of this cutting-edge research. Next slide. And for those of you who are new to the CFAR network, just to let you know that there are actually 19 centers for AIDS research that the NIH supports throughout the United States. There are many of the major research universities on this slide, and we consider ourselves very fortunate in DC to have a citywide CFAR that is part of this event today. Next slide. And just again, for people who know that we have 9 institutional partners, 4 universities, GW, Georgetown, Howard, and American University, 2 medical centers, the VA Medical Center and the Children's National Medical Center. And then we're very, very fortunate to have both the government, the DC Health Department as part of the CFAR, and our newest members are community-based organizations that are focused on research. Whitman Walker, and this year Us Helping Us, where Christian works, joined as a full institutional partner and is conducting HIV research as well. So there's a lot of people involved. We now have 283 investigator members and numerous interactions with the DC HIV community, of which tonight is a wonderful example of. So thank you to Christian and Melissa and Louise and everyone, Kenya, for inviting us to participate once again. It's really a genuine honor. Thank you.
All righty, awesome. We will briefly introduce, I want to get salutations correctly, Dr. Monroe, Miss Ann Monroe. Monroe is the project director of the DC cohort, which I'm sure most of you are familiar with. It's really something that DC is very proud of. We've got over 8,000 people enrolled in just collecting information about folks living with HIV. So she will give us sort of an update of where we are in 2023 and what was presented at CROI earlier this year. She is also a professor at GW in the Department of Epidemiology within the School of Public Health. So Dr. Monroe, if you're ready.
All right, great. Thank you so much. I am also very excited to be here and to present this DC cohort work with you. So let's go ahead and get this rolling. Okay, so this evening, I will present the results from the DC cohort at CROI 2023. And I'm presenting on behalf of my co-authors who I'll acknowledge in the final slide. So many of you are familiar with the DC cohort study, and I agree with Christian. This is something that we're all very proud of within DC. It is a longitudinal multi-site cohort of people with HIV in DC. And what it is really is a large database. We enroll as many individuals who are receiving their HIV care as possible in DC. And then we receive information about those patients with regards to their treatments, both HIV treatments and non-HIV treatments, their medical and mental health diagnoses, lab results for both HIV and non-HIV labs, and procedures that they undergo, such as cancer screening procedures like mammography or pap smears. And what's really unique about this is it's a citywide initiative. We have 14 clinics that participate, and they represent academic clinics, so hospital-based clinics, as well as community clinics and government clinics, so the VA is included as well. And this data from the electronic medical records, or EMRs, comes to a centralized database at the GW Biostatistics Center monthly, which means that we're able to get very timely information, which is fantastic. We have over 12,200 participants, so this is meant to be representative of the city of DC. It was in fact inspired by the Framingham study, which was a citywide or town-wide study of cardiovascular disease. And so the idea here was to have a citywide study of HIV outcomes. We have active community advisory board participation and close collaboration with the health department, where we do a linkage of DC cohort data with health department data and other infectious disease databases. So this project is really unique to DC. It's a wonderful resource. We invite collaborators from all different disciplines to work with us to get the most that we can out of the data set that the participants have voluntarily joined so that they can contribute to improving HIV care within the district. So with that background, I'll jump right into some of the results that we presented this year at CROI. All right, so the first study reflects the fact that we have been enrolling patients in the DC cohort since 2011. So we have many years of data. And this study involved 8 years of data looking at the care trajectories or patterns in an urban cohort of people with HIV receiving care in Washington, DC. And we know that people transfer in and out of care. They might be lost to follow-up. And we also know that individuals who cycle in and out of care or who have inconsistent care have higher risk of virologic failure and death. So the objective of this study was to really take advantage of this long-term data we have on the individuals who have enrolled to identify their trajectories or care patterns and to characterize them. And so we used over 11,000 of our DC cohort participants. We used special statistical modeling that allowed us to identify these care trajectory groups. And based on the data, we were able to distinguish 4 different levels of engagement in care based on somebody having a care visit or a lab within the past 200 days, divided over 8 years. So we had those who were highly engaged throughout their time, medium engaged, meaning that they had some changes and loss of follow-up, gradual disengagement, meaning they went from disengaged to completely unengaged over time, and early disengagement, meaning that they quickly, after engaging in care, dropped off. And we checked many different characteristics to see what was related to engagement in care. So we checked age, sex, race, insurance, housing, substance use, length of HIV, viral suppression, and the number of other medical comorbidities that they had. And so this is a really nice figure showing our results. So as I mentioned, based on the data itself, we had 4 different groups. We had individuals who, over the length of the study, always stayed engaged in care, and that's the high engagement group in the green. We had the medium engagement group who were somewhat engaged, but not the same level of engagement, meaning not having consistency with their visits and labs as that high engagement group. We had the gradual disengagement folks who started engaged, but then gradually fell off over time. And then we had the early disengagement who started engaged in care, then quickly dropped out of care by 600 days. And so pulling that information together, the main finding of this study was that when we looked at longitudinal care trajectories using all of the information, not just 1 or 2 years of retention, we found that as many as 1 in 5 individuals disengaged in care early after cohort enrollment, so that early disengagement group, and multiple factors influenced long-term care engagement. So I mentioned that we checked lots of different things to see what was associated with engagement. And we found that people who disengaged early were unfortunately less likely to have preserved immune function. So they were more likely to have a CD4 count less than 500. And of course, those are the people that we would most like to keep, because with a lower CD4 count, those are the people who are at high risk of having adverse or untoward outcomes from their HIV infection, and who were not virally suppressed, who had non-permanent housing. Now, interestingly, we found that individuals who were privately insured were also more likely to disengage early. And that could be that they had private insurance from one source and then lost a job, had to get new insurance, and perhaps had to go to a different clinic. So that's what we think the private insurance association with early disengagement might represent. We found that people who were younger and male were more likely to disengage early, and people who had been living with HIV for a shorter period of time, independent of their age, were more likely to disengage early. So what does this mean? So using these characteristics of those who disengage from care, using these longitudinal or long-term approaches, can help guide intervention development to really help improve care engagement. What do we do with these groups of people who are at risk of being disengaged from care to try to do a better job of retaining them? And one of the ideas that's been put forth to help keep people engaged in care is using differentiated care models. So really trying to meet the patient's needs depending on the level of need that they have, and having a care model that is more aggressive for people who need more support, and perhaps provides less scaffolding and less structure for people who are doing okay without that level of support. So I think I'll hold questions for the end if that's okay. I'd like to quickly go through all 3 abstracts, and then I'm happy to, after Kenya does the community response, we'll have time for Q&A then, or perhaps at the end, but if it's okay, I'd like to just keep on going through the abstracts.
Sure, go ahead. And
Okay,
folks have questions, I hope they're taking notes. Go right on ahead.
Okay, all right, or put them in the chat, or, you know, I'm definitely happy to take questions, because these are a little bit complex statistically, and they're a little much to get. You know, we might have to look at the figures again or do something again just to kind of help this help kind of cement these ideas. All right, so the next one was actually similar, but looked at states of engagement in care. So the first one really looked at modeling engagement in care over time, and this one looked at different states. So the states that people could switch in between were being engaged in care, meaning they had a viral load CD4 or visit within a 200-day interval. So the 200-day interval is a little longer than 6 months. And we would like people to have at least one visit in that 200-day period. They could have a short-term disengagement where they had a 200-day period without any care. They could have a medium-term disengagement where they went 400 days or about a year without any care, and long-term disengagement, meaning that they had more than a year and a half without care. And then they could transfer and get their care elsewhere, or they could pass away. So these were the 6 states that we examined for these 11,255 individuals who were included in the analysis. Okay, so here's another very nice figure that one of our analysts made. And basically what it's showing you is in this first panel, it's showing individuals who started out engaged in care. So they had a visit in their first 200-day interval. And for most of those people, or over 80%, the idea that they would stay engaged in care, that they would transition to engaged, they go from engaged to engaged to engaged to engaged. So these are the individuals who stay in care once they're in care. A much lower proportion of them dropped out, transferred, or died. The next figure shows individuals who started their follow-up or had a subsequent follow-up period where they were short-term disengaged or had a 6-month disengagement period, more or less, about a little more than 6 months. So you can see that for those individuals, if they started as disengaged, it was about a 50-50 split for those who would go back to becoming engaged or who would go to medium-term disengaged, meaning having that 400-day period of engagement, with a lower proportion of individuals who transferred or died. If they started with a medium disengaged interval, the chances that they would ever make it back to engaged with that purple line are very, very low. And if they started disengaged, long-term disengaged, it was also very, very, very unlikely that they would make it back to engaged. So this analysis focuses on stage transitions, with most of the people who started engaged staying engaged, and it becoming less likely that people who were long-term disengaged would make it back to care. So our results and conclusions show that the probability of re-engaging in HIV care decreased over time. So once you get out, unfortunately, based on our analysis, it looks like you stay out. And we also think that the implications of this work are that interventions to identify those at risk for early and sustained disengagement should focus on ART initiation, because we found that people who started on therapy were more likely to stay engaged, and then structural level supports, because we found that individuals who had unstable housing were less likely to stay engaged. So not only ART as a method to keep people in care, but also structural supports such as housing. All right. So then our last analysis was something very timely that we were able to do very quickly at the time of the Mpox outbreak last summer. So we were able to very quickly launch a survey of Mpox awareness, risk reduction, and vaccination among people with HIV in Washington, D.C. This is one of the things that I love about the cohort, is that we're very able to be nimble. When something arises, we can talk to the principal investigators and community advisory board at all the different sites, and we can very quickly launch something new. And so if we wanted to get information about Mpox, that's something that we can be very nimble about and do quickly. And so these results actually involve information from August of 2022 to January of 2023. So we had 201 individuals who responded to this survey, and the data was analyzed in January 2023, because by then the outbreak had started to decline and the conference was in February. So we got as much data in as we could before the conference deadline. And so what we wanted to do with this analysis was look at factors that were associated with vaccine acceptance. So out of the 201 people, some people reported that they had been vaccinated. Some people reported that they planned to get the Mpox vaccine, and other people indicated that they had no plan to get the vaccine. And so we wanted to look at what the characteristics of those individuals in each of those groups was. And we also wanted to see how people changed their behaviors in response to the Mpox outbreak. Okay, so I keep on having to move my, your pictures are in the way of my slides. And I love seeing all your faces, but I keep on having to move you guys around. Okay, So the main finding was that out of the 201 individuals in the survey, more than half had been vaccinated or planned to vaccinate against Mpox. So we had 201 people with HIV who were enrolled in the DC cohort who took the study, the survey. 43 of them had vaccinated, about 80 planned to vaccinate, and about 80 did not plan to vaccinate. And we can look at some of the differences between these groups. So the individuals who did not plan to vaccinate were older. They were less likely to be male. So we had more males in the vaccinated or plan to vaccinate group versus the no plan to vaccinate. Individuals with a higher education level were more likely to be vaccinated. Individuals who were single or never married were more likely to be vaccinated. And individuals with a lower household income were less likely to be vaccinated. MSM for their HIV transmission risk group were more likely to be vaccinated, and individuals with a high CD4 count were actually more likely to be vaccinated. So, you know, as many of you know, Mpox was more severe in people with lower CD4 counts. So honestly, you know, with regards to that result, we would have liked to have seen at least equal levels of vaccination among those with lower CD4 counts, or higher vaccination levels among those with lower CD4 counts. But we saw higher vaccinations among people with high CD4 counts. All right, then move on to the next slide. Okay, so this again, we've got fancy pictures this year. So this picture shows the predicted probability of vaccinating, or how likely someone was to be in this vaccinate group, plan to vaccinate, or no plan to vaccinate, based on some of their characteristics. So you can see that we have males and females, and of course, sorry, so sorry. Okay, so we have MSMs in green, non-MSM males in purple, and females in orange. And we have our group of individuals who vaccinated, plan to vaccinate, and no plan to vaccinate. And we have these individuals' ages. So you can see that among the youngest individuals who were MSMs, they had the highest predicted probability of vaccination, and young women had the lowest predicted probability. For people who said they planned to get vaccinated, you have about a 50% probability of non-MSM males and females in this lowest age group, and that remains pretty consistent over the age span. And then the no plan to vaccinate, the women were more likely to be in that group, especially older women. So better uptake of the vaccine among young MSMs compared to older women. Okay, we also had MSM more likely to report protective behaviors and negative impacts of Mpox. So this figure shows the impact on behavior change by group. So MSM were more likely to report behavior changes such as limiting the number of sexual partners, as well as an equal number of men, women, and MSM men, non-MSM men, and women avoiding skin-to-skin contact. That was increased throughout all those groups. Non-MSM males were most likely to report no impact on sexual behavior. And then with regards to the negative impact of the Mpox outbreak, MSMs were most likely to report a negative impact on intimacy and sex, their sense of safety. And then the other characteristics were a little bit more equally distributed across groups, with the exception of non-MSM males reporting a stronger negative impact on their sense of well-being. So what we found in this survey was that more MSM employed risk reduction behaviors and vaccination as Mpox prevention strategies. And I think it's important that we ensure that all people with HIV, regardless of gender, sexual orientation, or age, understand the risks of Mpox, because that may improve vaccination uptake. If people perceive their risk to be low, they may be less likely to get vaccinated. And so trying to give people the information they need about protective and preventive measures is important so that we can perhaps get higher rates in some of these groups. All right, and so those were the 3 CROI abstracts from the DC cohort. Here are the full references for those. And so, of course, I'd like to give a shout out to all the co-authors and lead authors on these abstracts. And then this is the full page of acknowledgements for the DC cohort. And as you can tell, we have citywide representation. So many people go into making this study work, and we are funded by the National Institutes of Health. So thank you so much for inviting me to share that information, and I'm happy to take questions.
Question.
Hey, Wallace, how are you?
I'm fine. How are you?
Good.
This is a quick question. Where would the transgender population fall into if it's male to female, female to male?
Okay, that is a great question. And I will tell you, we did not divide that data out for the abstract, but we certainly will divide that information out for the manuscript, for the paper. And I would be happy to circulate that to this group of attendees in a follow-up correspondence.
Thank you.
Sure.
So before more questions come in, we asked a leader in the city and in the community to sort of engage with the material, sort of prepare some remarks, and just sort of respond to what, you know, they think the implications of this might be. And I think the point in having Kenya go first, maybe his questions will be similar to other questions in the room. Maybe the conversation between him and Dr. Monroe also will just generate new questions, or even just answer some questions that you might have. So Kenya is the Deputy Director of the Center for Black Equity, and also an active member of the DC Center for AIDS Research Community Partnership. So happy that you took time today to join us, Kenya. And feel free to respond to Dr. Monroe's presentation, and we can take it from there.
Awesome, thank you. Yeah, so my name is Kenya Hutton, Deputy Director, he, him pronouns, Deputy Director of the Center for Black Equity. First, thank you all for having me here. Again, I think y'all had me before, and you know I tend to ramble. Also, thank you, Dr. Monroe, for their presentation.
Sure.
I did have some points. Wallace actually brought one of them up. Where does the trans community fit in this data, as well as where does women fit in this data, especially women of color? And if we could get the data broken down by race, gender, sexual orientation, just a full breakdown. One of the things that's from community is that we don't get the full picture. We don't get the information. We get sound bites. You know, I've been doing this for a little bit of time, you know, about 26 years, not that long. And that's been the reoccurring theme, is that people want more information as it comes from the higher ups, right? They don't want the sound bites, they want to get the full picture, is what the feedback I've gotten in the community work I've been doing. And I'm glad you talked about MPOX, because at the Center for Black Equity, we did a research project that started September of last year, that ended in March this year, where we developed a best practices for community engagement and MPOX, a best practices toolkit for advocacy and collaboration with local health departments and MPOX messaging and vaccine efforts, which I'll be happy to share the links in the group once I finish talking. But also out of that, one of the questions was community impressions on MPOX, right? And if I may, I'd like to read some of the responses I got to the question that said, what are your thoughts on the containment of MPOX situation in the United States? So I'm not going to read everything. I'm going to read some of the main ones. That was not enough information. Just like HIV, it's everybody's worry. We could have done much better with all we learned from HIV and COVID. This one was personal, where it said, I feel they don't care about containing MPOX, or they would make better restrictions and more ways to access on how to prevent catching it. Again, back to that information piece. Feel they could be more transparent in this issue. Marketing is of importance. Ease of vaccination delivery. People are concerned about there being another outbreak. Believe again, it wasn't taken seriously. The role of the vaccines was a hot mess. It was disappointing to see that we've learned nothing about containing pandemics from coronavirus. Feels like more could be done. Just from the media, I feel like more folks has a positive response to the vaccine and monkeypox just from social media. Need more data, etc. Not good. I don't think it's contained. From that, social media was mentioned, which I think we really need to see more of that, really getting the information out to where folks are getting it, because community members aren't joining these kind of meetings, right? Community members aren't watching the news or attending CROI to get this information. So as a research institute, you know, if you can work with community and getting this information out, I think that's the main thing I really want to drive home here is communication. You know, the research is done at such a high level, a lot of folks don't really get information, and that's really what is been an echoing sound from community members that I talk to, not just in DC, but around the country. So let me just say that. I'm not just focusing on, I'm not saying just DC, this is a national issue. Communication and getting the information out in a transparent way. And when you're marketing it, I think one of the issues was it was marketed to gay men that were high risk because of certain activities, and that created a space where some community members didn't feel they needed to get the vaccine, even though everybody was eligible to contract mpox, right? Just like HIV. So I think, you know, that was a big misstep earlier on, and I, you know, as a community leader and someone that speaks for community often, I just want to echo that if we can, from a research perspective, make sure we get that information out to the community members that need that information. It's not going to take long. That's all I really want to say, was just say what the community has given me so I can share it with you all, because I don't think everyone has seen that information. And I'll drop the link here. There's also HIV messaging among the Black and queer community toolkit as well. Feel free to use it as much as you like, if anyone would like. And that's all. Thank you.
Thank you,
Kenya,
Kenya.
thanks so much.
Mhm.
Oh, sorry, so it took me a second to get off mute, but thank you. Yeah, so I think a couple ways that we try to get the information out, and we can certainly do more and certainly can do better. We do have a newsletter that we distribute to all of the participating sites in the clinics, which is actually a paper newsletter that sits in the waiting rooms so that people can look at it while they're waiting to see their doctor or provider. You know, it's to help us try to reach individuals who are not connected to the internet, or you know, to try to access the populations who are actually coming to the clinics, which certainly doesn't reflect everyone living with HIV in the district, but that's one way we try to meet people where they are to disseminate this information. And we also do have a community advisory board, participants from each clinic, and so they come to regular meetings and receive correspondence from us, and again with the hopes that they would disseminate that to their networks who might not be as connected to this info. But I think making this information digestible in a way that people can use it is really important. And I think that's one good thing that came out of COVID, is some of the dashboards that finally health departments finally got them going, and I think any person could use them, and they were understandable. I think that was a really nice thing that we were able to do during COVID, that hopefully some of those lessons were learned when mpox, I felt like that data came online a lot faster than it had for COVID, but again,
yeah,
it's still not enough. So I agree with you.
Yeah, DC was definitely, I will say DC was a leader in getting that dashboard up. It took a couple, you know, we went through a couple iterations, but it was good and it was pretty fast. So I definitely would want to commend you all in that for the work that went into that. Yeah.
Let's see.
So we certainly do have a few minutes for 1 or 2 questions for Dr. Monroe, or even for Kenya directly. If anyone in the audience wants to ask anything about mpox, about the DC cohort data, about folks staying engaged in care. I saw someone come off mute. Go ahead.
Hey, this is Wallace again. So just an observation, and maybe a general observation, that when you're talking about monkeypox or mpox, that probably most, if not all, the gay men that are in rest homes or facilities did not get engaged in that because of stigmatism, or you know, being stigmatized in the rest home by being, well, why do you need this? Are you gay? And so that's something we can look at in reference to a population that is hidden, but really does exist.
Yeah. I just want to echo what you just said, Wallace, and also want to say one more thing, because I know Ann mentioned that you all work with community advisory boards and hope they take the information and give it back. But I think really giving folks some talking points, some simple talking points that they could relate, because they might get information but not know how to get it back out to community. Some simplified talking points I think would be important.
I agree.
I want to escalate a question from the chat before we go to Moises. This is from Melissa earlier. It's about how the DC cohort data is basically organized. So do the 14 separate sites see their own data or the general data? And are you able to break it down to individual site reports that might allow a site to mitigate disengagement and develop re-engagement for patients? So how does the multi-site collaboration kind of go?
Yeah, so thank you. One of our innovations is our DC cohort dashboard. We had it first. No, I'm just kidding. Kaiser probably actually had it first. Lots of people had dashboards before we had a dashboard, but we love our dashboard. So the dashboard allows the site principal investigators or research assistants to see their own site's information in aggregate, like summary statistics for that site in terms of their engagement, retention, how many people are on ART, how do their labs look. And beyond that, it allows them to download. We have all of the information identified by like a patient ID number. And so within the dashboard, the users who have access to that, which is the site principal investigators and RAs, can download a list with the DC cohort patient identifying numbers, and then link that back to their clinic charts. So they can use that as a tool to actually do individual outreach to people, which we're really happy to give people that capability to use. They submit information for the research study, but it also gives them a product that they can use. And so we're hoping that it would be used that way.
Awesome. This dashboard, we might have to do a workshop on how to see this dashboard in the future. Or something like that. Moises, what's your question?
Oh, you're
You're
muted.
still on mute.
I'm sorry. You made a statement out of the results of this that that the probability of people re-engaging into care in HIV care decrease over time.
Yeah.
And that is I think it's a very important piece of information in terms of, when we talked about, again, demographics go, I'm going the route of health disparities here. When we talk, we keep talking about re-engaging, but I think there is a real issue about sustainability of that engagement, and how and what motivate people or the specific group or demographic that is having trouble re-engaging. And if it's, the groups that I suspect are, there is also something to say about health disparities and how these groups already come to the system with sometimes hesitations about engaging in care or not having the sufficient, psychosocial support. Or, when we talk about the disparities, also, we talk about the history that people bring with them and how they relate to that system, and knowing that it's a systematic, problem. So this piece about people not over time, not re-engaging, I think it requires and need more research.
Yeah.
And also we're completely committed to ending the epidemic. I think that we could not ignore that fact.
Yeah, I completely agree. Thank you so much for bringing that up. And, the barriers to re-engagement are high. There's so many hurdles that people have to jump through, and if their motivation or their ability, if their life gets more chaotic and it's harder to overcome those barriers, it's really hard to stick with it. So I think you're right. How do you do that on a long-term basis when people are living with this for their whole life? It's a really hard thing to do.
We have time for these two questions in the chat before we move on, or this last one is pretty quick. How are individuals that transfer care categorized in the report, right? Because they may have engaged in the DC cohort and
Right.
consented at one site, did they go to another doctor? You
Yeah,
know.
so we have that one status of transferred. So if we discover, the research assistants discover that a patient has transferred, like they've moved to Florida or they are getting care at the AHF clinic or something like that, then it's documented as transferred in our DC cohort database, and we don't expect to see any more information coming in for them from their original clinic.
Okay, thank you.
Mhm.
The last question in the chat brings in pre and post / during COVID trends, and I'm actually going to save that for the open discussion at the end, because I think that theme, we may be able to pull some pieces from Mania's presentation as well.
Okay,
so with that being said, we'll transition over to our second scientific update and presentation. Thank you so much, Dr. Monroe.
Thank you.
Very interesting. We appreciate you.
Right back
Of
at you.
course.
All
So
right.
we'll bring Dr. Magnus to front and center, who is the co-director of the DC Center for AIDS Research and the interim chair for the entire Department of Epidemiology at GW School of Public Health. I asked someone earlier today, oh, do you know, everybody knows Mania. I was like, oh yeah, I guess that's how people feel. My ED is making funny faces to distract me, but I won't let him. Yeah, so without further ado, Mani, if you want to bring us up to speed on what's going on in your research world.
Well, thank you so much. Thank you to the organizers and to Christian and Melissa and George and Lorena and Alan for having me. I do feel so delighted to be here with you on this wonderful occasion. I'm a big fan of this event, so I was happy that it worked out that I could join you. I'm going to be talking today. Actually, I'm going to be bringing back data from CROI to you. Can everyone see the screen? Great. I'm going to lift up this bar because you're right, Anne, that bar looks like in the way. There we go. I'm actually going to be bringing back data from CROI to DC, as we sometimes do. The studies I've chosen to highlight here, actually 2 of them were conducted here. So they're ideas generated in concert with the DC work, but they're not actually our data. So I want to just make a little note that what I'm doing here is when it's a report back from CROI, I have a little icon about CROI in the upper left-hand corner. When it's my own takeaway, then you'll see it's clearly just a regular PowerPoint slide. But I want to be very sure the investigators that I'm citing here, many of them are close colleagues. They're remarkable humans, great data, great protocol teams. So I just want to be clear what I'm bringing back, and it's not necessarily my particular research. So today, what we're briefly going to go over, I'm just going to set my timer so I stay on time. Recognizing I do talk quickly, and if I talk too quickly and you need to have updates after, ask me questions, I'm happy to clarify those. But we're going to talk about some of the HIV prevention work and also some of the HIV treatment work with a focus particularly on access and removal of barriers. One thing I thought, and I'll be interested in the thoughts of others who attended CROI this year, that we finally have gotten to the point where it's not only science, it's also the science of how we get science to communities and to humans. And I was very excited about that. So that's where I've chosen to focus my 15 minutes. I have no conflicts to disclose. So I want to highlight, first of all, some of the amazing updates just to bring us through the generations of PrEP, pre-exposure prophylaxis, and where we are. This was a wonderful session led by Rafi Landovitz. Rafi is actually our close colleague of ours at UCLA. He is the protocol chair for HPTN 083, which was the registrational trial for injectable cabotegravir, now known as Apretude. And Rafi is a well-known expert in PrEP. We've known him actually since about 2015, when we were part of the early development, the phase 2A trial of HPTN 077, which was the early trial of injectable cabotegravir in healthy volunteers. So I want to just walk us through the last couple decades in pre-exposure prophylaxis. And as you'll all remember that TDF-FTC, also known as Truvada, as an oral daily pill, was published in the IPREX study with Grant et al. In 2010, subsequently approved by the FDA in the United States for prevention of HIV in 2012. Since then, we've recognized so much can work in prevention. We've leveraged this knowledge. It's been a remarkable prevention trajectory. It's actually extremely exciting time. I'm an HIV prevention person, as most of you know. So I'm living my best life knowing we have these wonderful tools to prevent HIV. We know, for example, the ring is available, the dapivirine ring. It is not yet approved here in the United States. It is being approved elsewhere in the world. A recent publication just came out actually yesterday that Zimbabwe demonstration project, where it is approved, is showing actually that rates of real life use of the vaginal ring in women and cisgender women is actually comparable to lots of different types of PrEP. So we are starting to have new methods of intervening and stopping the acquisition of HIV. We also know that the Discover trial, which looked at a new sort of next gen oral medication called Descovy, was shown to be effective to prevent HIV, and it was FDA approved in the United States for use by transgender women and cisgender men, although cisgender women are still not approved, highlighting inequity. And finally, HPTN 083 with injectable cabotegravir, near and dear to our heart. We are part of the original trial, so we're very excited that that did show superiority to HIV prevention. So this is a walk through memory lane. This is just a study trial design. We've talked about this in our community outreach a lot. This was the original design, and I'm happy to answer questions about this of HPTN 083, of which we were one of the sites, and again showed superiority. And we see that we've just completed the year 1 unblinded analysis, which was presented by Rafi et al., as well as Hyman Scott, Meredith Clement, and several other of our colleagues across the HPTN, and showed in continuation of the superiority of the injectable cabotegravir over oral TDF-FTC. But what I want to focus on is not that. In the next, let's see, 9 and 49 minutes, I want to highlight on how we haven't done a great job at getting PrEP to the world. You can see here, this is global PrEP access here, and the darker sides on the right show the increased PrEP initiations around the world. And the global picture, almost 4 million initiations in the fourth quarter of 2022, not bad. Pretty good, looking great there. We can see here we go from 2016 to 2022. It looks a lot better. The darker blue indicate increased PrEP initiations. Not so bad. However, what we don't see here is what is missing. The people who need it, who do not have it, do not have access to it, or will have access and still can't get it. And that's where we think Croy did a great job at highlighting some of these ideas behind structural barriers and not only the science of the medicines. So I want to focus now in the United States, since we are here in the United States again, but not to the exclusion of global scene. I think there are similar disparities in the global situation, but I'm going to focus on the United States here. You can see these are slides from AIDS View. We've, again, from left to right, you can see remarkable increases in PrEP. We are doing better. It's getting more common to have people on PrEP. We can see modest declines, probably attributable to COVID, but an overall steep incline with regard to PrEP access, all good. But what we still continue to see is that the people who need pre-exposure prophylaxis in the United States are not the ones getting it. So this comparative, also by AIDS View, highlights the percent of new HIV diagnoses in 2020 relative to the percent of new PrEP users by that same demographic. So you can see that Black people, Hispanic, Latinx people, and white people are exactly opposite in terms of need based on HIV prevalence and incidence and percent of PrEP users. So this tells us that something we are not doing we are not doing something we need to be doing so that we can get PrEP to the people who need it. So why is this? But before I go on to why is this, I want to say, here's a small deja vu. So I had the benefit of working with all of you, because I love this particular event, several times before. So in 2016, I reported back on PrEP from Croy, and it was the same story then. And again, in 2019, I reported back, and again, we saw these same disparities. And so my question as an HIV prevention researcher is why, and what can we do more than we're doing to ensure that we can, this life-saving tool can be spread across the people who really need it. My take on this is barriers still remain. Despite numerous options in PrEP, regimens, different medications, the people who need PrEP are still not accessing it. And the challenges to widespread use include cost, adherence barriers, stigma, knowledge deficits of both providers and those knowing it even exists, provider capacity not up to snuff. Structural barriers are rampant in this area, and then logistical challenges. So the next talks I'm going to highlight were given at CROI, very innovative talks. I encourage you to watch them. I've provided the links at the bottom so you can go home and watch them. They're free. And they highlight paradigm shifts we might need to take if we want to overcome these structural barriers for often forgotten populations, as well as global scenarios. So I want to turn now to my close colleague, Dr. Laurent Nelson. He is a close colleague in the HIV Prevention Trials Network, and many of us work with him. He's at Yale. And he was the protocol chair for HPTN 073, which was a study that we conducted here through the HIV Prevention Trials Network site at George Washington University under the leadership now of Dr. Mark Siegel and our whole team. And we were one of 3 sites in HPTN 073, and Laurent is the protocol chair of that. So this talk was, I thought, just a truly outstanding talk, because Dr. Nelson looked at how we are viewing these structural determinants and how we might be able to shift our paradigm. This was the most un-CROI-like talk. CROI doesn't often have talks like this. This is a very un-CROI-ish talk. It was truly outstanding. Again, please listen to it. But what he pointed to is that these structural barriers, and I'm a structural barriers person, I find myself very engaged with this dialogue, really looking at them not in terms of what they are as static ways, but the mistakes we make and how we are not able to address them. So he looked at several mistakes and how we can try to change how we think about them. And what he really pointed to, and you can look at these here as I go ahead and discuss them, is that we keep thinking of social and structural determinants as static backdrops, existing structures, but not realizing that they're there and they're consistently reinforced and re-engaged because they work for a lot of people. And we can talk about this in detail, what that means in the questions and answers if you're interested. But what really means it's not just propped up in kind of a crumbling structural determinant package. It is things that are actively being reinforced by people who can benefit from them. And so we need to really look at their functions and see how we can sort of take them away from the functions to undermine them. He also talks about how we can target the structural and social drivers and think about these things as modifiable. They're not static, they are modifiable. Now, one thing he presented, which was really remarkable, was how some of our data have been used to examine this very fact. So the HPTN 073 data, he had a very revolutionary idea, and we looked at it. The paper is cited here, there on the bottom left, where we took the 073 data, and under his leadership, we looked at how well those data using structural equation models looked at self-determination theory. And if you give people the tools to autonomy, will that increase their actual hard outcomes of PrEP utilization? And in fact, what we found was yes, that people can know about PrEP, they can access PrEP, but it's their self-determination to use PrEP that we need to support. And that's a modifiable factor. So it's not only changing insurance, it's also helping people to have autonomy over those, and that yields freedom and hopefully engages in use in PrEP. He also pointed to a book I haven't read and I can't wait to read, which is Thomas Kuhn. The book is cited here, and I'm not going to be able to do it justice, but I encourage you to listen to his talk. But that we need to paradigm shift and have scientific revolutions that disrupt these structures. And if we can do that, then we could possibly reinvent the PrEP access and also healthcare access overall, and get rid of some of these disparities that continue to plague us year after year. I'm going to turn now to Dr. Solomon just very briefly. Dr. Solomon is also an HPTN. He's at Hopkins, and he talked about long-acting PrEP and the need for it to be applied for people who inject drugs. Now, we know there are tremendous gaps in our knowledge about people who inject drugs, but he highlighted that we tend to think more in terms of people at risk of HIV who are in the MSM population, but we really omit a lot of people who could more benefit from injectable cabotegravir than almost anyone else, and that is people who inject drugs. Up on the pictures on the left in people who inject drugs in Ukraine, and on the right in India. And he highlights that the people in the same period of time from 2017 to 2019 of 782 people in New Delhi, there were 160 seroconversions compared to the almost 8,000 people in HPTN 083 and 084 in the same period of time when there's just a handful of seroconversions. Now, not to say a handful is not anything, it's tremendous, and we need to make sure we find ways to share this prevention method across the board. But it's important to note that there is something we might be missing, and I recognize in myself that we're missing this. We are now working on a study called HPTN 094, the Integra study, where we're working with people who inject drugs here in DC, and it's critically important that we are noticing that long-acting injectable PrEP could be used among a whole host of populations, even though there are a lot of questions. Lots needs to be learned. There's missing data about drug-drug interactions. We need to understand the efficacy of people who inject drugs. There are other populations, those who are incarcerated, those who are unstably housed. These answers about structural barriers need to be provided before we can launch this life-saving mechanism to all populations, including people who inject drugs. And this talk is remarkable. Again, I encourage you to watch it, but these are the highlights. Finally, he highlighted some of the unique population-specific barriers for PrEP for this population, and especially with a focus on injectable cabotegravir. These include many of the same barriers we're familiar with: cost, prescribing, specialized access. How do you get medications to people? Will they be acceptable? Lots of people who inject drugs do not want to have other medications delivered by needle into them. This is an important consideration we have to understand. Logistical challenges of people who don't have stable homes and may not be able to have phones. The PK tail, which we've talked about in the conversation about injectable cabotegravir, is very important. We could talk about that at length later, but the newly recognized testing requirements for viral load testing to ensure people are not quietly infected, and the potential for new development of resistance is really important. So we need to develop these as tailored mechanisms to help people use injectable cabotegravir that involve not just giving them a shot, but a whole host of supports and paradigm shifts, again, scientific disruptions that will allow us to get these life-saving techniques to people who can benefit. Now, finally, I want to highlight that there are a lot of phase 1 studies that are going on that on PrEP that were shown at CROI. There's long-acting subcutaneous injections and oral formulations that are underway. There are rectal douches, implants are coming, patches are coming. We've done broadly neutralizing monoclonal antibodies for prevention. Those are coming. Multi-prevention technologies that prevent pregnancy, HIV, and possibly someday STIs, all are along the pipeline. But I want to highlight that we need to address some of the challenges that remain for those that are currently approved or emerging approvals, including oral long-acting injectables and dapivirine rings for women, cisgender women. Now, finally, last but not least, I have just a couple more slides. Thanks for sticking with me. Barriers to HIV prevention, I don't think they're that much different from barriers to HIV treatment. The generalizability from clinical trials to populations who need them are the same. We need to address the structural barriers, they're the same. We need population-specific tailoring, again, they're the same. And then the real-world issues and how we get people in care and keep them in care in ways that work for them are critically important, and they're the same whether it's prevention or treatment. Now, in the case of long-acting treatment, Dr. Monica Gandhi, who's at UC San Francisco and is, of course, a leader in the field, she led a really important study, a demonstration project at Ward 86 in UC San Francisco General Hospital, which she presented on. Again, I encourage you to listen to her talk, where she looked at how they could practically overcome these remarkable barriers to long-acting injectable treatment for ribavirin and cabotegravir, also known as Cabenuva. So I'm going to go very briefly over these, but it's really important that what they did was they sort of said, we can't do the expected protocol. We need to do something that works for the people in our clinic. And the Ward 86 clinic, as she described them, have numerous challenges. They have high mental illness rates. They have high substance abuse, unstable housing. They can't just do all the stuff that people in affluent or highly resourced situations can. So what they did was they changed the paradigm. And she said these words in this talk, which I really liked, which is we need to creatively and boldly work to end the HIV epidemic. Again, scientific revolutions, paradigm shifts. And what they did was they said, you don't have to be virologically suppressed. You just have to have no mutations of resistance. And you kind of have to want to come get these monthly shots. And what they found was, in fact, that the people in this highly high need clinic had almost the same types of outcomes as those people in the clinical trials. Despite very different need circumstances, it's because the structural barriers were overcome for their population in this demonstration project. So what's exciting is, and she remarks in her conclusion, that the long-acting antiretroviral treatment has the potential to achieve this if we can just find a way to deliver it boldly and creatively. And by changing some of the requirements and making it accessible, we could model an end to the HIV epidemic by just using antiretroviral treatment in long-acting ways. So she mentioned that the AIDS Clinical Trials Group, and that's, for example, the Whitman-Walker ACTG clinical research site, which is a part of our DCCTU. They could possibly one day do this. We are not doing this yet, but in the future, they and the other ACTG networks could be a part of this innovative approach. So what are my key takeaways? And this is my last slide. Thanks for bearing with me. We need to urgently change the paradigms to overcome these structural barriers for both PrEP and for treatment. We have the tools, we have the science. Now we need the science of delivering these tools to communities who need them. And that will help us overcome healthcare disparities. It will help us overcome these almost insurmountable problems, because we cannot change everything. But if we identify what we can change, if we disrupt the structural barriers that continue to work for some and refine them so that we can allow everybody to access these amazing technologies, we will probably be able to end the epidemic. And I was delighted that CROI brought these really broad thinking scientists to speak on this. And I thought that was hopefully interesting to you all. And I'm also excited they regarded our trials here with 073 and 083. So it had a little touch of DC, even though they weren't from our own data. So I will stop sharing there and hand it over to the community response, which I'm looking forward to because this is a shared thing.
Thank you so much, Manya. We will definitely jump right over to our community response. Just want to say thank you so much for centering structural barriers and not thinking it as a sort of afterthought, and acknowledging that it has to be part of biomedical prevention. Yeah, thank you. So Moises, who spoke a bit earlier, we're going to invite him to give a response to some of what Dr. Magnus presented on today. Moises is currently the Director of Treatment for NMAC, and an active member of the DC Center for AIDS Research Community Partnership Council. Moises, I think I saw you in Vegas just last month.
Yeah, I saw you.
So nice to see you here again today, and feel free to take it away.
Thank you, Christian. Great presentation. Thank you, Dr. Magnus, for it. I found it really great that you wrote the presentation about the structural barriers, and also, you know, how important self-determination theory could be, and also the quality of these people, these structural barriers to not being static, you know, that there are ways that we can, you know, influence them, change them. And it just took me immediately to the importance of trauma-informed care. And that, you know, I think that it's not only about the house that you don't have or the boss that you can take. It's about that, but it's also about, you know, the trauma that a lot of the patients come, and not only the individual, but, you know, systematic generational trauma. So thank you for that. I think that's very informative and important. Also, you know, how modifiable was the word I was looking for. The other thing that I was made me think about was about the long-acting injectables, and you know how we have jumped into the long-acting injectables, and everybody has making an effort to, you know, be on it. But one point that I think that we should be very cautious about is that they will not be for everybody. What I mean is, you know, in a lot of conversations with some of my peers, and when I say peers, you know, all people like me, is that a lot of people are having a hard time conceptualizing having an injection when they're doing so well and they have systems already in place, taking their pills. A friend, the doctor was insisting, but you know, he was concerned about that and concerned about the monitoring again of it. So that is something that we should keep in mind also. And one thing that I saw in one of your slides was you talked, there was something about integrase inhibitor resistance. And I don't know, I was hoping to hear about some new drugs that may be, you know, maybe under study. Like I went to Croy, I was glad to hear about islatravir, which it was a drug that was put a stop because of their prep they were showing the drop on CD4, but it seems that the company fixed that. So the FDA gave them approval to come back. And, you know, the good thing about that is that, you know, their resistance barrier is very high. And for a lot of people that are aging with HIV, there is a need for new medications. There are people that come with multiple resistance to not just one class, but multiple classes. So it is very important to understand the choices and options that are coming down the pipeline. So that was one of the things that I was looking at Croy. And then the other question was the study that Dr. Gandhi was doing. Was it in a study, a clinical trial environment, or it was a community clinic? Just thinking about monitoring mutations is not that easy sometimes. So,
is it okay if I just answer those questions, Christian, or should I wait till later? I'd love to I can just give a quick response. Would that help, or? Yeah, well, I'll just go ahead. If I don't want to go out of order, but first of all, trauma-informed care, yes, I think that's the next horizon. And I think that's something we have to learn how to study. We have the tools to study these innovative ways. It's not all implementation science. Implementation science has the idea that it's just, you know, how can we roll out stuff? But we also have unique study designs that can look at differences in environments, and that trauma-informed care, I'm very, very much in favor of that as something we need to go to the next level to study how well it works, because that could fix a lot of things without fixing only one thing. That study, so I'm just going to bracket this by saying I attended the conference, so I don't know more than I saw from Dr. Gandhi's talk. But my understanding was that it was at Ward 86, which is in the community-based clinic. It was not a clinical trial. It was a demonstration project. So it was really like, you know, regular care. That said, regular care in San Francisco is probably a lot different than regular care a lot of other places. Their ability to access, you know, mutation data, et cetera, is probably a light years ahead of most of us. But one thing I was impressed by, and just methodologically, I think that what she said was that they were analyzing the data in real time because it's not a clinical trial. It was a demonstration project, so they could look at it quickly, and that they made a remarkable pivot based on the real-time data that they saw. So I feel like that is something we can all benefit from. That's, you know, it's clinical trials need to answer questions, but once we know the questions are answered, let's not keep asking them. Let's use our clinical trials methodology to rapidly pivot and address the real people's needs based on their data really quickly. So I think she did a really cool thing with that I was very impressed by. But again, I don't know her, and I wasn't part of that study, so I have to be careful. I don't know more than I just said. But
Thank you very much.
I'd
Thank
love to,
you.
we should have sit down and talk more about this, because I think we share a passion for structural barriers, and I'm always excited to talk to people with that shared passion.
Anytime.
All right, Christian, I'm sorry I hijacked that. Back to you.
Timing is perfect. Thank you, Moises, for bringing up some important themes. I think trauma-informed care. I mean, that was the first time we had really discussed that today on this call, for example. And you also did bring up aging, which I think is a recurrent theme that definitely warrants more research attention. So at this time, we can actually sort of go into an open conversation, open discussion. We have just about 15 minutes before we wrap up. Melissa, I'd love to invite you to help facilitate this part of the event. And I even see you have a few questions in the chat, Melissa. If you want to bring those to the presenters, that would be great.
Thank you. Thank you. Can you hear me?
We can hear you great.
Okay, good. Thank you. This has been very inspiring. And I so appreciate everybody's perspective. And it sounds like Croy is finally understanding that it's not the products themselves that are going to end the epidemic for us, as marvelous as they are. We just won't be able to inject our way or pill take our way to the end of the epidemic. We will need to address these structural barriers. We absolutely have to. We won't get to the end. And I was very pleased to see that they had community members in plenary sessions, like opening plenary sessions, not like final day at 5 o'clock plenary sessions, but actually at the opening sessions of the Conference on Retroviruses and Opportunistic Infections. So clearly they're beginning to understand what's needed, that we need all hands on deck. And we do need to look at the whole person in the context of their lives, in the environment in which they're functioning, in which they live. And we have to address those things that are dismantling their the person's ability to gain the maximum benefit from these products that we do have available to treat HIV and to prevent HIV. So I'm glad to see that there is some understanding of the whole person and their environment and the structures, meaning the unemployment and the education and the caregiving needs and the transportation and the knowledge, the awareness and the capacity to be able to access care and to be able to stay with care is so critical. And I think that Dr. Monroe started us off with this conversation with the DC cohort data and the challenges with engaging our population right here in Washington, DC, with the incredible resources that we have here. But there's still challenges. There's still some barriers to overcome to make that care accessible and available to the people who need it the most. And so thank you for that dialogue on that, and so the dashboard tools that help each of those 14 sites in the DC cohort project be more aware of their population and their ability to gauge in care and stay in care and to benefit from care. And I certainly appreciate the MPOX conversation, which is just one example of many of how these structural barriers create hurdles for the people who most need the vaccine and the care and the resources to be able to get to it, and how we sort of carve out people and try to identify who's most at risk, but then the others that are actually at risk can get lost when we start trying to compartmentalize. And I guess the solution is to try to find a way for the information, the resources to be available to everyone, so that we can get the information out there to those who most need it. So I would be interested in some of the speakers' comments about the questions that have been posed in the chat. And are there antiretrovirals on the horizon for those who might be aging, living with HIV, who have been on treatment for decades at this juncture, who are virally suppressed, but are concerned about what happens if they begin to have some breakthrough virus on the regimen that they're currently on. I am interested to know from perhaps Dr. Magnus's perspective, and also Dr. Monroe, who is a researcher, but also a clinician here at the DC VA Medical Center. Any thoughts that you two might have on any new antiretrovirals that might be on the horizon for our population?
I'm going to pass that to Anne because I am focused on prevention and that is completely hers. So I'm sure she's got answers.
So I think with regards to the concern about breakthrough when people are on stable ART, we don't have any data right now that suggests that as long as people remain adherent to their treatment, which is a big if, that's a big challenge, right, to take these medications every day. However, if people are able to maintain adherence, there's no evidence currently that will suggest that their treatments will stop working because of virologic failure. Now, they might still have side effects that prevent them from continuing on a certain medication as they age. They certainly could have kidney issues or perhaps cardiac issues that would necessitate a change to a different agent. And so I think the quest is always to find safer, better, more tolerable, more efficacious medications, because certainly, but I do reassure my patients that there's no indication that we have that one day your meds will just stop working from a virologic standpoint, as long as you're able to adhere to them. In terms of new things on the horizon, different long-acting formulations that are not just injectable, I think are the next big thing. And so we're all looking forward to having more options for long-acting medications beyond injectable meds, such as some of the oral long-actings. And so I think that'll be the next innovation that we see widely available.
And is it because we do have a population who are stable on their medication, virally suppressed, but we also have people who have been disengaged in care, who do have active viral load, who have had some spotty adherence for a variety of reasons and may need a new regimen because of their resistance. And so what are your thoughts on new medications and their formulations, either in long acting or pill taking or infusions or what have you? Are there new drugs coming?
Yeah, well, so one that was recently approved, and I'm so sorry, I'm having a senior moment and can't recall the exact name of the drug, but there was a recent formulation for people with multi-drug resistant HIV, and I'm sorry, I don't have the name off the tip of my tongue. If anybody else in the audience does, I'm humble, and I would invite you to please throw it in the chat.
Lenacapavir?
Lenacapavir.
It's a capsid inhibitor.
Yeah,
from Gilead.
I think that you have it, and so yes, so for people with multi-drug resistance, there are new options. I don't know how much of the pipeline is focused on people with treatment-resistant HIV versus how much of the pipeline is currently focused on getting more options available for example, initial therapy of HIV or therapy for people who are suppressed with longer acting formulations. I sense that will be where most of the emphasis is, rather than on developing a lot of new medications for people with extensive drug resistance.
Okay, thank you. Thank you. I just want to tackle some of the questions in the chat here.
Earlier, I had passed on Marcia's question, actually. So maybe we can circle back. Dr. Monroe, did you all look at any trends with COVID within the DC cohort data? I'm sure you did. If you could maybe give a brief synopsis of what you saw.
So I did this is an analysis from Corey last year. So first of all, I did an analysis that looked at the early the early pandemic period. So March to June of 2020 versus March to June of 2019. And we actually found more completed visits. And we hypothesized that was because of more people using telehealth. So people who actually had struggled to get to clinic, that they were able to be reached by phone, and that we actually saw in those initial 3 months of the pandemic better visit completion compared to the same period in 2019, which we thought was really interesting. But the picture changed as more data became available. This is an analysis. Shannon Barth is actually on the call. She's one of our analysts. This is work that she and Dr. Castell presented last year at CROI, showing care engagement in the pre versus peri-pandemic periods. So you can see it significantly declined. However, ART prescriptions were maintained in the pre versus peri-pandemic period. And you can see here that unfortunately our achievement of viral suppression in the pre versus peri-pandemic in DC cohort participants also declined. So, and it's interesting, in my own clinic, I've kind of moved away from telehealth because I found that I was having visits with people while they were driving to work, or I felt like telehealth was a great tool in the beginning, but now I'm really back to in person for most people when they can make it in. I'll still do telehealth if they want it, but trying to really get our engagement and viral suppression back up to the pre-pandemic levels is something that is really important to us. So those are my comments on that one. We're complete with a graphic. Thank you, Shannon Barth.
That was beautiful. That was beautiful. Do you have any graphics up there about, Chanton is asking about individuals that transfer care from site to site. Perhaps is that data being captured in DC cohort data? And do we have any data on the number of homeless? Are we capturing that in our DC cohort data, or even those who might be newly engaged in care with immigrant status, for example? Are we capturing any of that data?
Okay, so immigrant status is, we actually don't capture that. We could capture we can capture somebody's insurance status. So, if they're only eligible for services through Ryan White, and we do capture people's country of birth. So you could kind of deduct perhaps who might have immigration status based on what their country of birth is and whether or not they well, in DC they might be able to get DC Alliance. I would actually have to dig in a little bit on that in terms of what healthcare coverage people who are undocumented in the United States could receive, and a huge invisible homeless. Yeah, so we do collect information about housing status in the DC cohort. And we know that we do have a significant, probably 10% to 15% who have temporary unstable homelessness. And then the third question was, do we know who jumps from clinic to clinic? We do. I have a figure for that one. If there's another question that Manya can address, I can pull that figure really quickly.
Okay.
Would that be?
Good, Anne. That's impressive to me.
Yeah, Manya, if you wanna, I do think this issue around, you mentioned it when you mentioned 073 with that client-centered care coordination, self-determination, how we're looking at the whole person, or should be looking at the whole person, and the impact of people even recognizing how their trauma or their loneliness or their depression or their mental health, et cetera, might be impacting their care. So maybe you might recall some of the data from 073 addressing or how client-centered care coordination impacted care engagement.
Yeah, absolutely. In fact, as follow-up, I can send along some citations, but if you just go on a PubMed search of, they're all free online, HPTN 073, and we can give that information to you as well. But those papers do chronicle the primary outcomes of the 073 study. But the CFAR, or the client-centered care coordination that Melissa referenced, that was part of the whole protocol. In fact, it wasn't just an add-on, it was actually like integrated into the protocol in addition to the offer of PrEP. PrEP was very early back then. In fact, we just come off the heels of iPrex. So it was all very new, and this was a unique study by Black men who have sex with men, for Black men who have sex with men, led by members of that community. And it's a remarkable study because CFAR is developed specifically to meet their needs. And it was a really terrific manualized intervention to really address some of the trauma. And oh yeah, thanks, Christian. That's terrific. I can send those out. Thank you. Yes. But so it really to address those issues and really to, not just meet people where they are, but provide tools that can actually lend people self-determination actions, and as a sort of as part of that, remove trauma, although this was not a trauma-informed care specific intervention, it had those elements. So the C4 is just one way. I think that we need to have more studies. This was a remarkable study by the HPTN that they invested, that the NIH, NIAID, NIMH invested in studying not just a medicine, but studying a medicine alongside a behavioral intervention that can be implemented in clinics. And there is more work being done. There needs to be a study. There actually needs to be a randomized control trial to look at C4 by itself, because it's likely that that would have the capacity to improve care overall, not just related to PrEP, and try to address some of those numerous needs. And I saw the question in the chat about unstably housed people as well. What's great about C4, as well as trauma-informed care approaches, as well as other approaches we use to reduce structural barriers of care, are that whether someone is housed, unhoused, affluent, no access to medicine, has a job, doesn't have a job, C4 does functionally help people where they need help. And it empowers them where they need to be empowered. And so I think that's a unique approach that should be furthered. But again, the research on that is just beginning, because I think it's only now that the aha moment that we need to look at ways to deploy these interventions is becoming clear to people. So I think that we're going to see more in the future, and that will be really great. And now hopefully Anne has a slide, because she's remarkable that she pulled up these slides to answer the question.
After that, we'll probably close this out.
Okay, so this is from a publication. Okay, so this was a really interesting publication that Dr. Castell and others did in the cohort. So first of all, overall, looking at all 12,000 people who've ever enrolled in the cohort, and this is not shown on this slide, this is our overarching data. About 20% of them have transferred care, meaning they've left town, they've left their DC cohort clinic. So out of the over 12,000 ever enrolled, about 20% have transferred care. But this slide goes a little deeper, because this slide shows people who are attending multiple clinics within the DC cohort network, which is information that we're able to get through our DC cohort linkage. So you can see that the majority of people only attended one DC cohort site, but there was a smaller proportion who attended 2 sites or 3 or more sites. And we also see that those individuals who attended more sites, this green bar representing 3 or more sites, were less likely to be virally suppressed. So they were bouncing around. It looked like they were retained in care really well because they had visits. And, you know, their ART status was okay in terms of whether they had been prescribed ART, but unfortunately those individuals who are bouncing around were not, it's a sign of something, because the viral suppression achievement was lower in that group. So this is one of the studies we did looking at people who were not necessarily transferring, but kind of bouncing around. And so I thought I would share that with you all too, because I thought that was very interesting.
Thank you, Dr.
Thank you. Thank you for sharing that.
Of course.
I want to be respectful of this time. Definitely at 6:30. I want to thank everyone for coming. And just something that I was reflecting on is that we've been doing research for only not even 30 years, actually, right? What, you know, the HIV epidemic was going on before research started. But just imagine how far we'll be in another 30 years with how far we are today. We have so many medication options. We have so many gaps that have been identified. We have so many conversations that are just now starting. So I can't wait to be a part of these conversations in another 15, 20 years. Until then, I'll see you all next year at the 12th annual CROI update. I thank everyone for cutting time out of their evening, and I think we can dismiss the call.
Thanks for having me,
everybody.
everyone.
Thanks,
Bye.
everybody.
Everybody.
See you next year.
Bye-bye.
Thank
Bye-bye.
you.